Hi, my name is Jeff Petrella. I am a professor of radiology at Duke University in Durham, North Carolina. And I've come here to the Ceylon Conference 2016. Really have enjoyed my time here. I'm particularly impressed by the academic program and the quality of all the presentations. Spanish is not my native language, but I have an interest in it, and I've found I've been able to pick up quite a bit more than I thought I could. I've also been particularly struck by the welcoming that I've received here, and how people have really gone out of their way to see that I've had a good time, not only academically, but also really enjoyed and taken advantage of the social activities here, and that has been great. My area of research is imaging in dementia, and I have an interest in particular in using imaging biomarkers for early diagnosis in Alzheimer's disease and in other dementias. One of the problems in Alzheimer's disease is that the pathology of the disease develops really years to decades prior to patients becoming symptomatic. So we really have, and there's an indication that treating these patients earlier is better prior to their sustaining a lot of brain damage, essentially. So we have a large window, a large opportunity to treat these patients. So the key really lies in diagnosing these patients early and using biomarkers, namely the tools that we have in neuroradiology, to help identify these patients earlier so they can receive the therapies that they need. There's been obviously there's been a lot of work in looking for cures for this disease, and I think one of the biggest problems is after even 100 years of research, we still don't know essentially what causes the disease. We have some ideas. The problem is doing clinical trials and testing drugs is extremely expensive. So I think one of the areas where we can help as radiologists, as neuroradiologists in particular, is being part of these clinical trials and bringing our imaging tools to these trials so we can, number one, identify patients who are going to benefit from these therapies. We call that enriching our sample. So we're choosing patients who really have the disease pathologically, not patients who just present with a clinical diagnosis. So I think we can really help these trials by enriching which patients who are apt to benefit most. We can also help these trials by using our imaging tools to identify very early changes from the therapy that we may not be able to detect clinically. So using those tools, we can identify, this therapy is actually working here. Let's invest more money in this therapy and not this therapy. Essentially separate the winners from the losers, and take the winners to the larger, more expensive clinical trials where you need to really see a cognitive benefit before you're going to use that widespread use in patients. I think functional imaging has really revolutionized neuroscience research. So the study of the normal brain and how the brain functions. And I think we're just beginning to look at how function changes in disease. And I think, once we really have a handle on that, can understand that, then we could start using it for diagnosis. But it's really a step-by-step process. I think particularly in the areas of psychiatric disease, where we on traditional imaging, we really have no means of identifying or diagnosing these diseases. Diagnoses are difficult to make clinically. There's a lot of discrepancies between two different psychiatrists, for example. So functional imaging, I think, by looking at abnormalities in brain networks and identifying a biological basis for these diseases, I think is really sort of the next frontier in imaging. Right now we don't contribute much to this area because we can't see very much. But I think with tools like functional imaging and diffusion tensor imaging, we can start looking at the miswiring of the brain and identify abnormalities that we can begin to see objectively. There are about 20 million people worldwide with Alzheimer's disease. So it's a significant amount. In our country, the United States, there are about 5 million people. And I think we're really scratching the tip of the iceberg there, because we know these are people who are diagnosed clinically, who are symptomatic. Again, we know that the pathology starts years to decades before patients become symptomatic. There's a big prodromal period for this disease, and we really are not doing mass screening to identify that, to really have a handle on what the incidence of the disease is. Because we'd be looking at patients who are asymptomatic and younger, patients who may be in their 50s, 40s, and 50s. We've even identified abnormalities in patients who have genetic risk, who are in their 20s and 30s. You could actually see on imaging brain abnormalities in these patients. The benefits of living in a society where we have medicine that extends our lives means that, since age is the biggest risk factor for dementia, that the incidence is increasing, is forecasted to almost triple by the year 2050. So think about the tremendous costs, economic burden that this can cause. I mean, not to mention all the other issues associated with the disease.